మండే దేనికి సార్?
అదే ప్రీ క్రిస్మస్ పార్టీకి మండే పెట్టుకుంటే అవుతుందా అందరికి?
ఓకే సార్, గ్రూప్ లో అనౌన్స్ చేసి చూద్దాం సార్.
ఎందుకంటే మండే తర్వాత అందరు సీనియర్స్ అందరూ ఉండట్లేదట.
ఓకే సార్.
సీనియర్స్ అంటే డేవిడ్, రామారావు,
షూర్ సార్, ఏముంది పెట్టేసుకుని ఎవరు వస్తారు సార్, అంతే అందరికీ
కిరణ్, చంద్రాసు.
ఓకే సార్. కిరణ్ రాజాం నుంచి అవుతుందా కిరణ్ నీకు? మండే ఈవినింగ్ సార్, నైట్ డిన్నర్?
మండే నైట్ డిన్నర్, అది ఈవినింగ్ 5 o'clock బీచ్ సైడ్ కదా అందరు అన్నారు. అంటే ముందు మనకు అవుద్ది అనుకుంటే అప్పుడు నేను వెళ్ళి అక్కడ కనుక్కుంటాను, అందుకని ఈరోజు. కిరణ్ ఉన్నాడు లైన్ లో?
సార్ గుడ్ మార్నింగ్ సార్.
కిరణ్ ఉన్నాడు సార్.
కిరణ్
సార్ అలాగే సార్.
24th అనుకున్నాం కదా కిరణ్, అప్పుడైతే తక్కువ మంది ఉంటారేమో, ఇప్పుడు మండే అయితే ఎక్కువ మంది ఉంటారేమో కదా?
అలాగే సార్.
అందరు వస్తారా మరి? ఒక ఇన్నోవా పంపిస్తాను
సార్. అందరూ అంటే గాయత్రి మేడం ఆల్రెడీ లీవ్ లో ఉన్నారు సార్ ఆ టైంలో.
ఎప్పటి నుంచి?
తను 18th నుంచి 23rd, 24th వరకు లీవ్ లో ఉన్నారు సార్ తను.
సో మరైతే
నేను జగదీష్ ఉన్నాను సార్, నేను వచ్చేస్తాను సార్, ఆలోచిస్తాను.
ఫ్యామిలీతో రావాలని కదా, బట్ మొత్తం అందరికి ఫ్యామిలీస్ అని చెప్పేసి అక్కడ ఒక ప్లేట్ 1400 రూపాయల ప్లేట్ 80 మందికి అని చెప్పాం అందరికి. మనం అందరం ఫ్యామిలీతో వస్తే సరిపోదన్న ఉద్దేశంతో. ఎవడు రాలంటే ఎలాగ ఇప్పుడు?
సార్ నేను మా వైఫ్ వస్తాం సార్, కుదిరితే మా పాపని తీసుకుని వస్తాం. కానీ జగదీష్ వాళ్ళ వైఫ్ క్యారింగ్ సార్, తను రాలేడు, తను ఒక్కడే వస్తాడు.
సో నలుగురేనా?
అవును సార్, 3 members ప్లస్ కిడ్ అంతే.
ఓకే. పేరెంట్స్ లేరా ఇంట్లో?
సార్ ఫాదర్ ఉన్నారు సార్.
మరి ఫాదర్ తీసుకురావచ్చు కదా?
అడుగుతాను సార్, జనరల్ గా రాదు సార్.
ట్రై చేయమ్మా ఎప్పుడు ఒకసారి.
అలాగే
అందరూ ఎవరున్నారు లైన్ లో? అందరూ
ఓకే సార్.
ఆల్రెడీ టోల్ మంచిగా రమణ ప్రసాద్ గారు ఏమో ఎవరైనా అప్పచెప్పి రావచ్చు కదా ఆయన డ్యూటీలో ఉంటే.
సార్ అది మా ఫాదర్ కొంచెం కష్టం సార్, ఆయన బెడ్ రిడన్.
అవును సార్, మీరు వచ్చి వెళ్ళొచ్చు కదా 2-3 hours.
అది మరి ఇక్కడికి డ్యూటీ కూడా.
ఓకే. అనిత ఏవి అంటే ఎక్కడ పని చేస్తారా
సార్?
అనిత ఏవి అని కనెక్ట్ అయ్యారు? ఎవరు పేరు? అనిత ఏవి అని ఉంది, ఎవరు?
నిన్న క్లాస్ లో కూడా ఉన్నారు సార్, మరి సార్ టీమ్ ఏమో శ్రీనివాస్ సార్
తెలియదు. శ్రీనివాస్ టీమా లేకపోతే మన ఎవరు? అరే వెళ్ళిపోయారు. ఓంకార్ టీమా? డిస్కనెక్ట్ అయిపోయారు.
అయ్యి ఉండదు సార్.
అయ్యో అడిగామని డిస్కనెక్ట్ అయిపోయారు పాపం. అది కరెక్ట్ కాదు కదా, మనం అడగకుండా ఉండాల్సింది. ఎక్కువ మంది కనెక్ట్ అవుతే బెటర్ కదా.
మామూలుగా అలాంటి ఏదో డిస్కనెక్ట్ అయ్యి ఉంటుంది సార్, వచ్చేస్తారు.
శారదా అయిపోవాలంటే మన శారదానేనా?
మన శారదా.
వాళ్ళని పిలిచాను, నేను వెళ్ళి పిలిచాను. మొత్తం అందరూ 6 మంది 5 మంది లెక్కేశారు వాళ్ళు. ఏం శారదా?
సార్
5 మంది లెక్కేసాం
సార్.
రేపు మండేకి ప్రీపోన్ చేద్దాం. రాణి మేడం లైన్లో ఉంటున్నారు.
హలో సార్, గుడ్ మార్నింగ్
మేడం. మండే పార్టీ పెట్టుకుందాం మేడం, వస్తారా అందరూ?
ఏమండే సార్?
అదే రేపు మండే 20వ తారీఖు మేడం.
తెలియదు సార్, ట్రై చేస్తాను. ఎందుకంటే నాకు చాలా పనులు ఉన్నాయి, ప్లస్ రాహుల్కి ఎగ్జామ్స్ ఏదో అవుతున్నాయి.
అనురాధ లైన్ లో ఉంది. సరే మాట్లాడదాం, గ్రూప్ లో మెసేజ్ పెడతాను, అడుగుతాను. అందరికి ఫోన్ చేయమని అడుగుతాను. ఇంకా చైతన్య కనెక్ట్ అవ్వలేదా? శేఖర్ చైతన్య కనెక్ట్ అవ్వలేదా?
Hello.
క్లాస్కి వెళ్ళావా సూర్య క్లాస్కి వెళ్ళావా ఫ్రైడే క్లాస్ ఉంటుంది కదా లింక్ పెట్టారు కానీ అది ఓపెన్ అవట్లే
It's better we shall make a list on the group, sir. They ఎవరెవరు వస్తున్నారు number of members లాగా మనకు ఒక రఫ్ ఐడియా ఉంటుంది. We shall ask today and tomorrow will give time. Like so కొంచెం లేట్గా జాయిన్ అయిన వాళ్ళు వీఆర్ ఆర్గనైజింగ్ ఏ ప్రీ క్రిస్మస్ సెలబ్రేషన్స్ ఆన్ మండే. Please post in the group how many people are coming. It's on Monday dinner. అంతే కదా సార్? From evening. This Monday, 20th.
Am I audible? Am I audible?
స్టార్ట్ చేద్దామా?
Yes, sir. Yes, sir. Investing, sir.
Yeah, audible and visible. Slides move అవుతున్నాయి.
Okay, okay. Starting now. So today our topic is anesthetic implications in rare cases like muscular dystrophies. Coming to the introduction, in muscular dystrophies are the group of genetic diseases characterized by compromised synthesis of proteins, muscle contractile proteins. These are hereditary and progressive diseases with unique phenotypic and genotypic features. The incidence of the disease vary from 1 in 10,000 to 1 in 1 lakh live births, and around 30 types of muscular dystrophies are there, but we are not discussing all of them. We are discussing only 5 or 6 major muscular dystrophies which are more common, and we will go into the evaluation and management. We will go into the clinical features and serious anesthesia complications in perioperative and intraoperatively, and clinical manifestations and preoperative evaluation and anesthesia management in this topic. So it's a pattern of muscle involvement which is more important in narrowing the diagnosis. Most myopathies present with proximal and symmetric limb weakness, and the reflexes are preserved, and the sensation is also preserved. Most muscle disorders cause persistent weakness. Hold on a second. We just okay. Just a second.
ఏమవుతుంది
ఇక్కడ ప్రొజెక్టర్ సార్, ప్రొజెక్టర్ yeah. So these are predominantly asymmetric and symmetric and proximal muscle weakness will be there, but however asymmetric and distal limb weakness is also seen in some myopathies, and most muscle disorders causes persistent weakness, not intermittent weakness. It is in majority of the cases. Most type of muscular dystrophies, polymyositis and dermatomyositis also, the proximal muscles are more weaker than the distal muscles. Often the facial muscles are spared in most of the dystrophies except facial scapulohumeral dystrophy. So facial weakness is only seen in facial scapulohumeral dystrophy. Otherwise, most of the muscular dystrophies are seen with proximal muscle weakness only. And if the cranial nerves are involved, then they are known as neuromuscular junction disorders. These are important for neuromuscular junction when the cranial nerves are involved. But in Aquapharyngeal muscular dystrophy, and myocardial myopathies and congenital myopathies, extraocular muscles and other renal nerves are also involved. Gower's sign, as you are particularly aware of this sign during our UG and PG preparation, Gower's sign is particularly useful in diagnosing the muscular dystrophy, particularly Duchenne's, and observing the gait of the individual may also differentiates the particular narrows the diagnosis of the particular muscular dystrophy, such as limb-girdle muscular dystrophy and lordotic posture induced muscular dystrophy and the waddling gait and toe walking. These are all things that is seen in most of the muscular dystrophies, particularly limb-girdle muscular dystrophies. There will be weak hip muscles and hypertrophied gastrocnemius and hyperextended knee joint will be there. In most myopathies, muscle tissue is replaced by fat and connective tissue, but usually the size of the muscle is not affected. And in some limb-girdle muscular dystrophies, actually the calf muscles are hypertrophied, and that's a true muscle hypertrophy. That is not a pseudo hypertrophy. It's a true muscle hypertrophy, and they will remain strong for a longer time than the other muscles. They will remain strong. Ultimately, they will also get affected, but these calf muscles remain very strong even late in the course of the disorders. And muscle enlargement can be due to, as I said earlier, due to sarcoid granulomas, amyloid deposition, or fat deposition, and these can cause bacterial and parasitic infections also. And there will be focal myositis is also the same. In contrast, coming to limb-girdle muscular dystrophies, there is a predilection for the gastrocnemius muscle atrophy rather than hypertrophy, particularly in these two varieties. That is, I will come into the classification later, but these 2B and 2L are particularly associated with gastrocnemius muscle atrophy. Atrophy of humeral muscles is seen in facioscapulohumeral dystrophy and EDMD also. And coming to the laboratory evaluation, as we expect, all the creatine, in all the dystrophies, creatine kinase levels will be increased. As you know, there are two types of creatine isoenzymes, creatine kinase isoenzymes. One is CKMM and CKMB. CKMM is more common for skeletal muscles and CKMB for myocardial muscles. So these two enzymes, if we can quantify the CKMM, then we can CKMM is myocardial and CKMB is so we can quantify the individual isoenzymes. We can come to a conclusion whether it is a primary heart condition or it is a skeletal muscle condition. All the liver enzymes can also be increased in these conditions, except for GGT. That can because GGT is only synthesized in the liver. So when there is a liver dysfunction, GGT will rise along with other enzymes also. But when there is muscular dystrophy, except GGT, all other enzymes, all your transaminases and LDH will also increase. These muscular dystrophies are often accompanied by endocrine abnormalities also, such as hypothyroidism and hypoparathyroidism. So hence, we need to check for other adverse studies, thyroid function tests and parathyroid hormone and vitamin D levels. And we also know that we have to differentiate them from autoantibodies associated diseases such as myositis and other systemic disorders. The particular test of a forearm exercise test, which is very beneficial in identifying a muscular dystrophy, but not all muscular dystrophies are sensitive to this forearm exercise test. I will explain the test in the next page, and we can. So muscle biopsy is also helpful. Muscle biopsy is done in on all the superficial muscles, but it comes better with power of 4/5 in all. If a muscle has a power of at least 4/5, then the muscle biopsy report will be better and it is diagnostic. And the gold standard investigation is genetic testing, and every muscular dystrophy is associated with a specific protein deficiency. Hence, genetic testing and genetic sequencing of that protein can lead to narrow the diagnosis. Hence, it is a gold standard for diagnosing the muscular dystrophies. Coming to the electrodiagnostic studies such as NCV and EMG, narrow conduction velocity studies and electromyogram, these are helpful in differentiating from myopathies from other neuromuscular conditions, but they are not gold standard. But they cannot identify completely the individual muscular dystrophies. They can differentiate broadly from muscular dystrophies from other neuromuscular disorders, but they cannot distinguish individual muscular dystrophies. Coming to the treatment, the prognosis of the dystrophies is very slow and slow progressive weakness, and the severity is variable between individual subtypes. So some are associated with cardiac and ventilatory muscle involvement, and some are associated with distal muscle involvement, and most of them are associated with proximal muscle involvement of the limbs. So there are no specific medical therapies. Individually, Duchene's and Becker's are treated with glucocorticoids and most of the other muscular dystrophies are not having any specific therapies. Treatment is mainly aimed at maintaining the physical and occupational therapy. So occupational therapy and physical therapy is the most broadly used treatment for maintaining the muscle function and to decrease the severity of the disease and maintaining the function of the muscle for a longer period of time. And non-invasive ventilation and tracheostomy may be warranted in some cases where the respiratory muscles are involved. Cardiomyopathy is commonly seen in most of the muscular dystrophies and may require afterload reduction, antiarrhythmic agents, and pacemaker and intra-ICDs, and in severe cases, cardiac transplantation can be warranted. So cardiomyopathy can be HCM. Most of them will have a HCM, but in some muscular dystrophies, there can be dilated cardiomyopathy also. So coming to individual muscular dystrophies, Duchene's and Becker muscular dystrophies, these DMD and BMD are X-linked recessive muscular dystrophies, and Duchene's is more common and mostly affects the boys, and Becker's is more commonly affecting in the post-adolescent age group and in the 4th or 5th decades of the lifespan. So the X-linked both are because of the deficiency of the dystrophin gene. So, but in Becker there is only partial dystrophy, partial deficiency, and in Duchene's there will be a complete deficiency of the dystrophin gene. Both are associated with proximal muscle weakness, especially in the lower extremities. And DMD can be seen as early as in the first decade of the life. But as I said earlier, Becker's muscular dystrophy will be seen experience difficulties from the second post-adolescent age group and can be seen as late as 3rd or 4th decade. Life expectancy in both of them is reduced, but BMD can serve with Becker's. There is a better life expectancy up to 4th to 5th decade. Mental retardations is seen in both disorders, cardiac involvement is both in is seen in both, and some Becker's muscular dystrophy patients only manifest with heart failure, and there can be increased creatine kinase and myalgias without weakness and myoglobinuria. As I said earlier, glucocorticoids can slow the progression in Duchenne's only, but it's not that much helpful in Becker's. Physical and occupational therapy is important for maintaining the function of the limbs and muscles. Coming to the most common muscular dystrophy, that is limb girdle muscular dystrophy. Limb girdle muscular dystrophy itself contains almost 20 types of muscular dystrophies, which are divided into limb 1 and type 2 and type 1 based on the inheritance. Type 1 is autosomal dominant inheritance and type 2 is autosomal recessive inheritance. In that also there are multiple subtypes depending upon the individual protein involved. The prevalence ranges from 80 to 700 per 1 lakh patients, 1 lakh population, and the most common is 2A and 2I and 2L. These are the three most common limb girdle muscular dystrophies. So coming to Emery-Dreifuss muscular dystrophy, EDMD, there are at least 5 distinct forms. It is also a kind of limb girdle muscular dystrophy type 1B. As I said, it is autosomal dominant and it can be seen with hereditary cardiomyopathy, both hypertrophic and dilated cardiomyopathy associated with conduction and atrial fibrillation and AV blocks. There will be prominent contractures in the early childhood and teenage years, and the course of disease mostly presented with elbows, ankles, and neck. Muscle weakness affects the humeral and peroneal muscles, and it later spreads to limb girdle distribution. Female carriers of X-linked variant of Emery-Dreifuss muscular dystrophy are associated with cardiomyopathy. Even carriers of female carriers also can be associated with cardiomyopathy. Coming to the most studied dystrophy is myotonic dystrophy. Dystrophica myotonica, that is stenoid myotonic dystrophy. It is 2 types, type 1 and type 2. Type 2 is also known as proximal muscle myopathy. And these the clinical features are, as I say, it majorly involves the face. That is the typical appearance is hatchet-faced face, and particularly affecting the temporalis muscles, masseter, and facial muscle atrophy and weakness. There will be foot drop, frontal baldness, and palatal and pharyngeal and tongue involvement, dysarthria and dysphagia. This can cause dysphagia at a later, in a second decade or third decade of the life, and intercostal muscle weakness can lead to ventilatory insufficiency. Myotonic dystrophica usually apparent by the age of 5 years, and you can diagnose it by the percussing the thenar remnants and to close the fingers tightly and then relax. ECG abnormalities are first degree AV block and most conduction system and other conducting system anomalies, and as severe and it can be as severe as complete heart block, and sudden death can occur because of the complete heart block. And congestive heart failure is very infrequent, but carpulmonea can be seen due to secondary to respiratory failure. There will be decreased intellectual improvement, hypersomnia, posterior subtaxular cataracts, choroidal atrophy, insulin resistance, and decreased esophageal and colonic motility. These are all the individual symptoms coming to the myotonic dystrophica. And particularly DM2, that is the proximal myotonic myopathy, is particularly associated with proximal muscles, and the features overlap with type 1 myotonic dystrophica, and there will be testicular atrophy, insulin resistance and constipation, hypersomnia, and therapeutic defects. Cardiac conduction defects are less common compared to myotonic dystrophica 1. Treatment is only supportive treatment, and the treatment is not directed at the root level of the cause, only the supportive treatment can be given, and it can be, mexiletine can be useful in some conditions. It's only tried, but it's not proven yet. And cardiac pacemaker and ICDs can be used for arrhythmias and foot orthosis to stabilize the gait. Excessive daytime somnolence can be seen. So we can use modafinil and non-invasive BiPAP support and sleep studies to come to a conclusion to how much it can be reduced. Coming to the facioscapulohumeral muscular dystrophy, this is two forms of type 1 and type 2, and both are similar, almost in similar features. As you can see, there will be winging scapulas, proximal muscle weakness, particularly of the triceps and the biceps, and delta will be normal. There will be weakness in the wrist extension and anterior compartment of the legs, that leading to foot drop. Coats disease is a variant of the facioscapulohumeral dystrophy, which contains, additionally contains telangiectasias, exudations, and retinal detachment. Aquapharyngeal dystrophy, this is the one which is associated with the cranial nerves. Actually, it is not affecting the neuromuscular junction, but it is affecting only the extraocular muscles, leading to decreased extraocular muscle eye movement, and the main thing is any extraocular muscle involvement can cause diplopia. But in OPMD, there will be no diplopia because it is progressive. It is insidious in early phase, and it is slowly developing the extraocular muscle involvement. Hence, there will be no diplopia. There can be pharyngeal muscle involvement, leading to swallowing and increased risk of aspiration. Weakness of neck and proximal extremities can develop. It's an autosomal dominant disorder. There will be main complaint will be dysphagia that can be reduced with hypopharyngeal myotomy to improve the swallowing. Ptosis can be seen, and ptosis surgeries can be used to decrease the visual obstruction. This is the list. Coming to the last one, myrcene deficient congenital muscular dystrophy. It is a progressive severe muscle weakness since birth, multiple contractures, debilitations and disorders, scoliosis. Spine is particularly affected in this, and restrictive lung disease. It is autosomal recessive, and the incidence is 1 in 21,500 live births. Other less important dystrophies are distal myopathies. As I said, this incidence of these distal myopathies is very low, and these consist of Belander and Marksberry-Hicks type of distal myopathies. All are late onset, occurring in early 40s and in the fourth decade of the life. There will be anterior tibial muscle weakness and leading to foot drop. And one more myopathy is laying distal myopathy, which is autosomal dominant, with leading to characterized by tibial weakness, and it is but the onset is in early childhood and or early adult life. Coming to the pre-anesthetic evaluation, all these muscular dystrophies are associated with, we have to rule out difficult airway, because there will be weakness of the pharyngeal muscles, weakness of the respiratory muscles. There can be facial muscle weakness leading to distortion of the face and can cause difficulty in intubation and ventilation during the anesthesia. So we have to check these creatinine kinase levels, complete blood counts, coagulation tests, echocardiogram, ECG, and lung function tests also. Lung function tests of forced vital capacity of less than 50% of expected is warrants the need for postoperative ventilation. As you can see, this is the table where we can see what are the investigations we have to do for a particular type of individual muscular dystrophies. All the laboratory tests, including spirometry, arterial gas test, X-ray, are needed for almost all the muscular dystrophy, all the muscular dystrophies. Most of, specifically, some muscular dystrophies needing polysomnography, physiological studies, electrophysiological studies, and thyroid functions. Particularly, myotonic dystrophica is associated with severe muscle weakness. Hence, we need polysomnography, electrophysiological studies, including thyroid function. Other than that, most of the muscular dystrophies needing the echocardiogram, electrocardiogram, as I said earlier, creatine phosphokinase and RBS levels, electrolytes, CBC coagulation tests, and cross matching. So, and coming to the anesthetic management, difficulty, all the management of this dystrophies, muscular dystrophies is very difficult because of the risk of rhabdomyolysis, aspiration, malignant hypothermia, hyperkalemia, arrhythmias, cardiac arrest, and increase in muscle weakness and difficult airway management. So the risk depends upon this type and severity of the muscular dystrophy and the type and duration of the surgery. So not every case is associated with the same level of risk. We need to assess as an individual case, and we have to go for our own clinical judgment before planning for the anesthesia. There should be no extended fasting. The case should be planned as per the rules, as per 6 hours NBM, and after 6 hours he or she should be shifted to the OR, because extended fasting can lead to rhabdomyolysis because of that can cause lactic acidosis and everything. So complete monitoring of these patients intraoperative monitoring requires ECG, NIBP, capnography, pulse oximetry, and temperature. Temperature is very important. Diuresis, ventilation parameters, and neuromuscular relaxation. Administration of glucose-containing fluids decreases the risk of rhabdomyolysis and also decreases the risk of hyperkalemia. So these patients are associated with increased risk of hyperkalemia, as I said earlier, and aspiration risk prophylaxis can be done in emergency cases, such as in case of emergency cases with sodium citrate, metoclopramide, H2 antagonists. TIVA is the preferential mode of anesthesia management. Propofol is preferred unless the patient is having cardiac issues. If the patient is having decreased cardiac reserve, then you can go for etomitate or thiopentone. No volatile anesthetics should be used. All volatile anesthetics can cause rhabdomyolysis and myotonia. But sevoflurane can be used in children for induction without any side effects. Only nitrous oxide can be used. Nitrous oxide has got no contraindication. Rhabdomyolysis increases with decreased days, and the patient is having lighter planes. Hence, we need to particularly maintain deep plane of anesthesia with neuromuscular monitoring, because movement can cause rhabdomyolysis. Opioids, which can be used, are fentanyl and remifentanil. There is no evidence that morphine can be used or not. There is no particular evidence. That it's not well studied. For regional anesthesia is preferred unless there is scoliosis or kyphosis, because that can cause inadequate anesthesia and analgesia of a particular area. Low-dose ketamine and midazolam can be used along with regional anesthesia. So no scoline. Scoline should not be used, as it can cause rhabdomyolysis and hyperkalemia. And the onset and so now coming to non-depolarizing muscle relaxants, they act faster in these people, and their behavior is erratic. So avoid non-depolarizing muscle relaxants also. If at all you want to use rocuronium along with Sugammadex. Hence, because of these erratic behavior of non-depolarizing muscle relaxants, the neuromuscular monitoring is essential. Neostigmine may cause acute myotony, rhabdomyolysis, and malignant arrhythmias and heart failure. Hence, neostigmine use is discouraged. Prevent hypothermia, as hypothermia causes increased myotony, increased muscle tone, and it can cause rhabdomyolysis. Use only potassium-free crystalloids. Use glucose-containing crystalloids, but there is no contraindications for colloids. So, postoperative considerations and complications. These patients are associated with increased sensitivity to opioid side effects. There is increased risk of respiratory depression, exacerbated gastrointestinal paresis, increased risk of reflux, aspiration, and ventilation dysfunction. In case of respiratory depression, following reversal of neuromuscular relaxation, consider the coming out of deferring the extubation up to 24 to 48 hours using a particular score, that is myopathy intensity rating scale. Depending upon that scale only, you can extubate and by assessing the myopathy. Analgesia, no NSAIDs should be given. NSAIDs are associated with increased risk of rhabdomyolysis, and regional blocks can be given to supplement analgesia, and PCM, paracetamol, has no is not contraindicated in this paper. And no sedation or opioid analgesia in the postoperative period. As I said earlier, they are very sensitive to opiates. And extubation is according to, as I said, myopathy intensity rating scale. You can see the myopathy muscular impairment rating scale, that is, it is 1 to 5, graded 1 to 5. 1 is no muscular involvement because the muscle is healthy, having a good power. 2 is minimal signs, that is myotony, mandibular and temporal weakness, facial weakness, weakness of the flexor muscles of the neck, litosis, nasal voice, no distal weakness, except for the distal flexor of the hand. 3 is distal weakness, no proximal weakness except for the extensor of the elbow. 4 is mild to moderate proximal weakness. 5 is severe proximal weakness. We can only extubate the patient if the score is less than 3. Coming to the most common perioperative complications, this is the table that is the most common perioperative complications associated with dystrophies. Coming to the Duchenne and Becker, they are associated with arrhythmias and postoperative respiratory failure. There is all the dystrophies are associated with, as you can see, associated with rhabdomyolysis and hyperkalemia, and even death, leading to cardiac arrest and death. And prolonged awakening can be seen with muscle relaxants. These are all, as you can go through the table. Dystrophic myotonic is also associated with, as I said earlier, it is the main feature is conduction defects of the heart, so that can lead to complete AV block and sudden death. So respiratory failure, which is also seen in 40% of the cases. Coming to limb girdle muscular dystrophy, complete AV block, atrial fibrillation, pacemaker dysfunction can occur. Emery refers, it's a complete AV block, cardiac failure, and arrhythmias can be seen. And in medicine deficiency, there will be, it is particularly associated with difficult airway and rhabdomyolysis. Thank you. Stop this.
Sir, good morning.
Good morning.
Sir, how to differentiate GB syndrome from muscular dystrophy?
GB syndrome from muscular dystrophy. GB syndrome, there will be ascending paralysis. It's more of a neuromuscular thing, and there will be a history of infection or.
What is the specific test to differentiate GB syndrome from muscular dystrophy?
The only thing the gold standard test is genetic testing, sir. Otherwise, as you can see, all these are hereditary disorders. You can easily differentiate with genetic testing. Otherwise, you can go for what is that? Forearm test, forearm clenching test, which differentiate dystrophies from other things.
Sir, nerve conduction velocity test, incremental response in GB syndrome and decremental response in muscular dystrophies.
Nerve conduction, it can vary, sir. Actually, it is not a gold standard test, but individually, nerve conduction velocity can be used. There is no contraindication for using nerve conduction velocity, but it is not. But it's not gold standard for diagnosing this.
Muscular dystrophies, you told a variable response for non-depolarizing muscle relaxation.
No, I didn't say that. I said they should not be used. They are more sensitive, faster acting in the people.
So if I want to use a non-depolarizing muscle relaxation for muscular dystrophy, how much dose should I give?
You should actually avoid, sir. If at all, that's why they are preferring TIVA, complete total intravenous anesthesia, including only propofol and fentanyl and remifentanil without relaxing the patient, keeping in deep anesthesia. If at all you want to use, you can only use procuronium along with sugammadex. That's the thing that is there in the book. But if you want to give, recently we did a muscular dystrophy, but we gave only regional only.
If rocuronium is not available, you want to use vecuronium. How much dose?
There is no dose adjustment, sir. You can give the full dose, but the only problem is postoperative ventilation. You have to ventilate at least for 24 to 48 hours postoperatively before getting him out of the ventilator support. That too, you need to, as I said earlier, you need to go through the myopathy intensity scale, so that you have to assess the myopathy and then only extubate the patient.
No, I think we have to reduce the dose of vecuronium to 1/3 or 1/5.
There is nothing, sir. As I found, there is no dose reduction is not written in any book or any paper actually. You can use, but these are also dependent. Coming to the question asked by Dr. Jagadish Onkar, please comment on the patient of any dystrophy posted for LSCS. You have to go with regional anesthesia, Mr. Onkar, that should be enough unless there is it can be epidural or spinal, but unless there is a spinal abnormality, then only you have to go for general anesthesia with very high risk of postoperative ventilation and aspiration also. And in cesarean sections, better to go for labral analgesia, because even the uterine contractions and increased movement can cause rhabdomyolysis in the later stage of the labor.
Shaker, emergency cesarean section aithe full stomach not fasted.
Adhe madam, you can use sodium citrate and metoclopramide.
No, I mean like intubation ki rapid sequence. You
have to go with rocuronium, madam. That's it.
But rocuronium inka asalu reversal ledhu kada.
That's the only thing, madam. That's the only thing is postoperative ventilation and coming out of the ventilator support is difficult. But if you have a choice, go with reasonably. Otherwise, go with acronym, because other neuromuscular blockers, they are telling you should avoid other blockers. You can particularly cannot give scoline. You use only rocuronium and scoline for rapid sequence induction as per guidelines. But if you want to go for a rapid sequence induction, use rocuronium.
So scoline is it mainly worried about sudden rise in potassium, hyperkalemia, arrhythmias?
Hyperkalemia and fascinations leading to rhabdomyolysis, madam.
Okay.
And increased the rhabdomyolysis can increase the potassium, right?